Hi, I'm Brandon Mancini, Medical Director at BAMF Health. For Prostate Cancer Awareness Month, we're interviewing experts from across the country in all things prostate cancer. And today I'm joined by Dr. Bergsma, Associate Professor of Radiation Oncology from University of Michigan, who's going to speak everything radiation therapy for the management of prostate cancer. Thanks for being here.
Yeah, thanks for having me.
Yeah. So obviously September, Prostate Cancer Awareness Month, very important here for the United States to bring attention to prostate cancer. Why do you believe this is important, and what message do you hope patients and providers take away from it?
Yeah, that's a good question. I think it's an important one. Obviously, there's a lot of awareness about breast cancer and prostate cancer in general, but I do think historically it's something that people were a little bit afraid to talk about. Men's sexual health was somewhat taboo. There's a feeling that you didn't want to admit weakness or talk about those sorts of things if you're a man. Obviously, we know that's not true, and that can do a disservice to men's health if they're not able or feel capable of talking about those things. So one thing, it's trying to get rid of the stigma of prostate cancer and get men talking, but also aware of what options are out there. You know, just as far as the prevalence, it's a fairly common cancer, even when not screened. But certainly when we screen, we're going to find a lot of prostate cancer. A lot of men have prostate cancer and don't know it. It's the most common cancer in men aside from skin cancer. And it's also a common cause of cancer-related death. Not all prostate cancer is something you don't need to worry about. So certainly, if we can do things to identify those cancers that are going to cause men a problem, we would like to do that. And you know, one of the easiest ways for us to do that, if men have a primary care physician who they trust and see, is to talk about prostate cancer screening and to consider PSA testing as a non-invasive blood test that may possibly tip off the provider and the patient that they might have prostate cancer. Of course, that does not diagnose someone with prostate cancer, but it would lead to additional testing. Although sometimes given a negative image or stigma, the digital rectal exam, when done for the appropriate reasons, still has value in also detecting prostate cancer, especially in cases where men may be having symptoms that are consistent with prostate cancer, but their PSA is normal. So definitely something to talk about and know what you're getting into when you are meeting with your primary care doctor, but important. So this month, raising awareness about prostate cancer, what we can do to detect it so that we can treat it if needed before it becomes a problem. And obviously, whenever you're trying to develop new treatments, and we're constantly trying to do that, an important thing is funding. So raising money for trials and studies to advance the field of medicine, specifically treating prostate cancer, is a very important thing. So this raises awareness about what the hurdles are, tells us a little bit more about what it is and what the hurdles are in treating currently and where we're working to try to improve that.
Absolutely. And to your point, right, it's 1 in 8 men are diagnosed, nearly 300,000 new cases per year in the United States. And so right up there as the most common non-skin cancer. And so also to your point, with PSA being a relatively straightforward way for that initial screening, a relatively effective way at finding this early. And that's the thing. It's screening, it's early detection, and early detection saves lives, kind of goes all in with that. So absolutely.
Yeah, for sure.
As far as kind of your background in radiation oncology and radiation therapy and your career as you've seen things evolve in that space, specifically, obviously, the treatment of prostate cancer, what are some of the most exciting advancements over the last 5 to 10 years related to the way we deliver radiation therapy for prostate cancer?
Yeah, that's another really good question, and something that's been fascinating to see evolve. I finished training about 8 to 9 years ago, and a lot has changed. It's truly remarkable how much the landscape of oncology or cancer care has changed, but specifically within prostate cancer, both for early stage disease and for more advanced or metastatic disease. But historically, radiation had the biggest role in early stage localized disease and also when it had spread to lymph nodes, and then mainly as a palliative treatment when men had pain due to involvement of their bone. Historically was where we would use radiation, and for a long time, most men, they were treated with a long period of radiation, which could be onerous and could make some men choose to not pursue treatment, because we would commonly recommend 7 to 9 weeks of treatment. in the curative setting and sometimes longer treatments, even when the cancer had spread, just to help with pain. We thought that that was necessary. And that's the evidence that we had. But a lot of trials and studies and have come out since then, and it's shown that not only can we shorten the course of treatment for many men, which really eliminates one of the big hurdles or concerns with receiving radiation treatment, but also do it better. Of course, the primary role of treating anyone with radiation for cure is to eliminate the cancer. And we have believed for a long time that more radiation dose is key. So we've looked at doing dose escalation trials that look at giving more radiation to the prostate to eliminate the cancer therein. And those were successful at showing better PSA control. It did show more side effects in some cases. So certainly there is some amount of limitation to how much radiation we can give to the prostate gland. It's located inside the body, intimately located in front of the rectum and below the bladder, above some of the sexual penile bulb, which is important for sexual function, and nerves around there that are involved in erections. And then the urethra, the urine channel, goes right through the prostate. So certainly we can't cook it and expect no increase in side effects. So there's a limitation in how we can get radiation dose in there safely. So the last 10 years, we've seen a multitude of things that have been developed to try to do that safely. One thing for higher risk men that may need a little more radiation, using a combination of external radiation, which is the more typical form of radiation that men receive, where you come every day for a number of weeks and receive a small treatment. But then also combining that with an internal radiation treatment called brachytherapy, which historically involved what some men would refer to as a seed implant. That would be radioactive seeds that were implanted into the prostate and would remain there. And that was a way of combining the external beam treatments with the internal treatments to get more dose safely into the prostate, either brachytherapy by itself or commonly with external beam. So that was our main way of increasing the radiation dose safely. And the trials did show that that improved the PSA control as a surrogate of success. There was some cost and side effects, but an excellent option for men who needed more radiation dose. We've been able to utilize other things to decrease side effects, fancier radiation planning, where we are able to control better where the radiation dose is going. It's a lot of, we call it inverse optimization, but computer planning to get a plan that we feel is safer. And the computer can develop a much better pathway, understanding where the rectum is, where the bladder is, to find the best way to put the radiation inside and minimize dose to those organs. And then daily image guidance. So when a man lays down to receive radiation, there's some uncertainty day to day where that gland is. We know that bladder filling is important. We know that rectal filling, basically stool and gas, it's a normal physiologic function, right, that you can't control as well. But those things matter, and they do push around the prostate a little. So having a better way of verifying the placement of the prostate within that man beyond just setting up to some tattoos on the skin has been allowed us to use smaller margins of uncertainty, which lessen the area that we have to treat to make sure we don't miss. So that's another big advance. And along with the idea of dose escalation, a lot of those trials, and I'll get into this later and you will too, we didn't know where the cancer was as well. Whether it's confined to the prostate or possibly out, but when we have no evidence that it is outside the prostate, knowing where the cancer is in the prostate allows us to intensify treatment there now that we couldn't do before. We know that more dose led to better control of the PSA, but we didn't know where the weak links were. With multiparametric MRI and really seeing the subzones of the prostate and finding the higher densities of cancer that may be more aggressive, allows us to fine-tune even within the prostate where the radiation is going. And we can push more radiation dose to those areas to prevent or minimize the chance that those areas progress and still respect and lessen the rectal doses and urethral doses and bladder doses. So this is a great thing that we can do. Rectal spacers, which are a temporary biodissolvable gel that can be placed relatively minimally invasively through the skin between the scrotum and the rectum that could remain in place for the course of radiation and give a buffer between the back of the prostate and the front of the rectum, has minimized rectal symptoms, especially severe toxicities, and is a relatively minor procedure. So that's been very helpful and allows for what I just described, which is that dose escalation to the dominant intraprostatic disease much safer with limiting rectal symptoms. I could probably go on and on about all the advances, and we haven't even gotten into the situation of cancer that's spread outside, that there may still be a role for local treatment with radiation. But just as a start, those are all exciting things that have all developed either in the last 5 years or the last 10 years.
Absolutely. No, that's a lot. And I think also you kind of alluded to, right, historically, these treatment courses were pushing upwards of 9 weeks. Do you mind commenting kind of on the most modern, like if someone comes into your office and they're going to undergo what's considered the standard course of external radiation, what are the couple of primary options that they do?
And this is always important, as you know, Brandon, that every patient is different. And what one person had may or may not be appropriate for another person. And that's a little hard when patients are talking. And I encourage people to talk, right? But why did they get this and why did I get this? Mm-hmm. And some of that is physician preference or comfort or experience, but there may be reasons why a longer course of treatment was recommended. But in general, most men nowadays, if they still have their prostate, we're not typically doing 8 weeks of treatment, although some men, there are reasons we recommend that. Mm-hmm. Many men are candidates for 4 weeks of treatment, even if we're treating their lymph nodes along with their prostate. And there are certain men, a large number of men, that may be candidates for a very short course of treatment called ultra hypofractionation. Hypofractionation just means few treatments, or stereotactic body radiotherapy, SBRT, which is a highly precise conformal treatment that is delivering high dose to the prostate and minimizing as much as able dose to the organs nearby, and allowing us to deliver the treatment faster but still be safe. So this is something that's really taken off. There are multiple ways to deliver that treatment, but one platform that we use is CyberKnife, and then that's just one way of doing it. There are multiple ways, but for the right candidate, this is an awesome option to have their prostate cancer treatment in a shorter period of time.
Yeah. No, and I think the biggest thing as technology has advanced to allow these shorter treatment courses, right, they've done the trials to prove out that biologically these doses are similar, long-term outcomes, cancer control are similar, and side effects are similar or sometimes even less as a result of the shortened courses with the better technology. So I think along the lines of any number of weeks or treatments, it's all been fully vetted, fully tested out, and really encouraging to see kind of less treatments. Less visits is always something that patients are looking forward to. And to your point, that potentially allows more patients the option for radiation. If they live 2 to 3 hours away from a radiation facility and the only option was coming for 9 weeks, Monday through Friday, that's a difficult thing for a lot of people to do. But now with a potential 5 treatment option, that breaks down a lot of barriers and increases access, which is amazing.
And I think for that reason, historically, some men that the length of treatment would exclude them from being able to go through treatment, and they were often, as a result, the best thing they had was indefinite testosterone suppression. Yep. These are men now that may be willing to or able to go through a curative treatment that would allow them to either avoid that or to have a discrete period and then regain their testosterone and have a better quality of life.
Absolutely. Yeah, so I think kind of along those lines, from just side effects in general, whether it's from the testosterone suppression medication or radiation directly, kind of what are the typical anticipated side effects of prostate radiation therapy? And really, what are the biggest misconceptions you encounter during your consultations and meetings?
And I think I'll answer the second part first, because I have a phrase, as we often have a phrase. But essentially, you're not going to glow. You're not radioactive. You don't turn into the Hulk. Mm-hmm. Nothing crazy happens off the bat. I think some people do worry that they will be radioactive with external beam radiation. There are certain treatments like a permanent seed implant. Yep. And I didn't talk too much about the other way that brachytherapy is done, which is with a temporary treatment that you don't have any radioactive material in your prostate after that. But aside from a permanent seed implant, you're never radioactive. The X-ray therapy that is given, in some cases, there may be a different type of treatment called proton therapy that we don't offer in this area of West Michigan, but is being studied as a potential option. But you're not radioactive. There is nothing dramatic that happens from the time you come into the center, lay down, receive the treatments, and then go on your way. And some people, they don't know what to expect, so that's a concern.
Yep.
And it's more of a gradual development for many men, and it does depend a little bit about whether you're having treatment with your prostate still in place, or if you're having what we call salvage or post-prostatectomy treatment after a prostatectomy, where the PSA is rising and we're concerned about residual or recurrent cancer in the area where the prostate was, or the pelvis. So, but in general, either course is typically going to involve some amount of gradual fatigue, some amount of gradual urinary or bowel bother. That fatigue could be quite significant for some people. The minority of people, I'd say it's really debilitating. That's a small minority. But some amount of fatigue that gradually builds. Some men are fortunate to have no fatigue, and some amount of urinary bother that typically builds as the weeks go on or the days go on. The shorter course of treatment, where you're getting a little higher dose or more intense treatment each day you come in, could bring side effects on a little quicker, and those are still typically very manageable. A lot of the things that we're talking about as far as managing side effects for any kind of worsening obstructive symptoms, if somebody is already dealing with a little bit of that, they may be more prone to have a worsening of that. But it could be starting just low dose over-the-counter anti-inflammatory, adjusting the diet, certain things that could be irritating the bladder, caffeine and alcohol, certainly trying to talk them through things that we can do relatively easily. We may go to prescription medications that help with the bladder emptying or an irritable bladder. And then the bowel, it's typically a softer bowel movement, maybe a little bit of looseness, especially if you're treating a larger area, including the lymph nodes. Some men do have what we'd call frank diarrhea. And the larger the field, the more likely, if you're treating lymph nodes, that you might have a more significant case of that. And that requires more attention to diet and avoiding exacerbating foods, and maybe even using some over-the-counter antidiarrheals. But skin reaction is not typical. I think a lot of people don't know that, since a lot of radiation treatments, especially for the breast, involve a significant skin reaction. The dose or radiation amount on the skin is not typically enough to even cause redness. So fatigue and urinary and bowel bother, which is typically very manageable, those are the acute side effects that develop as the course goes on.
Sure.
And there are other side effects that may develop even after those abate or go away. They're typically more rare, but you could have some lingering urinary or bowel changes. Again, not typically life-changing, but something that you may notice. And very, very rarely do we see the things that we used to see more commonly, where we would have frank rectal injury, what we call proctitis or ulceration of the rectum. A very rare event now, probably 1 to 2 in 100 men long-term might have that. Some of that's due to better planning, and some of that is due to using the rectal spacer when needed, and also better understanding about post-treatment care and things to avoid. But other things, sexual function is often an important concern for men, and that may even factor in why do they choose to have treatment or not. Some men that are still sexually active, they're still valuing that part of their life. They're going to choose things that are less likely to derail that. So active surveillance, if they're an appropriate candidate. Obviously surgery and radiation have their pluses and minuses, and that goes into the individual discussion and personalization of cancer treatment for prostate cancer. But with radiation, it's more of a gradual development of erectile dysfunction, unless you're also receiving what we call androgen deprivation therapy, or ADT, sometimes referred to as hormone therapy, where we need to shut down, at least temporarily, the testosterone production to kind of starve the prostate cancer cells of their fuel. And then when we hit them with the x-rays, they're more readily damaged so that they can't recover. So that can affect libido, because your testosterone is at least temporarily low. Otherwise, the radiation effects that lead to erectile dysfunction are more of a gradual thing over years.
Sure. And for the short-term urinary or bowel bother, what do you typically see in your experience as far as how quickly those resolve after that last treatment of radiation?
Yeah. And a little bit of it depends a little bit again on how fast the treatment is given. But I tell men typically in the 2, 3, 4 weeks after, most men are getting significantly better. Especially with the urinary symptoms. The bowel symptoms for men that do require maybe a larger field to treat the pelvic lymph nodes and have had more diarrhea, most men they're resolving within the first month, and they may have occasional bad days. The very rare patient, probably 1 in 25, that even for 3-6 months after is still having a significant change in their bowel movements, and they're really having to watch what they eat and use Imodium at times. But those are pretty rare, and those men you can usually identify in advance because they have a tendency towards diarrhea. And we talk very frankly about, if they're already tending that way where it's an issue, it may be a slightly bigger issue or potentially a larger issue in the period after radiation. But even those men that have pretty significant bowel bother and diarrhea, usually within 6 to 12 months, they're getting close back to the baseline.
Yeah, and you kind of alluded to it as well. Like when someone comes in and receives a treatment with radiation, do you have any restrictions on what they're allowed to do throughout the day? Do they feel physically different on a day-to-day basis where maybe they can't go play with their grandkids or go to the gym or go for a walk, things like that?
Yeah, for sure. And people obviously want to know what they need to do, right? We ideally are one of our biggest advocates for ourselves as we, traverse any medical condition. And one thing I tell people again is that, hey, you can watch your grandkids. You're not radioactive, like I said. I don't really have any restrictions that I give patients. There are certain things that you may have heard or read. Riding a bike, obviously, in advance of a PSA test can cause a transient rise in the PSA that may not reflect a cancer process. But I have found a lot of guys that are active, they're weekend warriors, even in their 60s and 70s, and they're bikers, and they have continued to participate in those activities. And they may find some, slower times, or they're not going 20 miles anymore, they're going 18 or 15. But they have continued to participate in those things that they find great enjoyment in, and I don't really tell people they can't do anything.
Sure. Yeah, and lastly, kind of from a side effect perspective, one thing that we've talked about is kind of urinary incontinence or urine leakage after surgery for prostate cancer. Is that something that's commonly experienced with radiation, or how often would we maybe anticipate that?
Yeah, and obviously it is a concern that urologists will talk to patients about, and I think there's probably some misconceptions about how often or how severe the leakage is, and obviously there's things that can be done to lessen that after surgery. But coming into radiation, if they're coming out of surgery and they have a recurrence of their prostate cancer that we need to treat, we are cognizant of the fact that their threshold for getting leakage is a little less than a man with an intact prostate. And they could have transient worsening during treatment or even after. We really reinforce Kegel exercises and sometimes a formal referral to a pelvic floor therapy program to try to maximize their control. But I do tell them that that could take a slight step back. Often doesn't, but it could. And if you have any amount of urgency with urination because of some irritation of the bladder, they may not be able to hold that quite as well. But frank leakage during and after radiation is not super common, but it can happen and often resolve, as I said. Intact prostate, it's a very uncommon thing. Some men do have just a tendency towards urgency. They're coming in with existing, bladder issues, and those men might deal a little more with urgency that could lead to leakage. And men that have had procedures to address an enlarged prostate that might have affected their continence off the bat, they could deal a little more with that. But intact prostate leakage is less common during the course of treatment, and can happen long-term in a minority of men. There's probably an element of quality in how the radiation is done as well, and we're looking at all those things, the substructures in the pelvis, and trying to make sure that the radiation dose isn't getting too hot in areas like the bottom of the pelvic floor. And that's where having a better understanding about where we need to focus the highest radiation dose and where we can, take a step back, not only increases cancer control long-term, trials have shown this. an integrated boost to the imaging PSMA or MRI-defined disease is going to lead to better control of prostate cancer in general and in the prostate, which is a concern for men when they're going into treatment because we always want options, and we don't want to treat the prostate and then completely treat the disease there.
Yeah.
But in addition to increasing the dose where we think it needs to go, we can also take just a little bit of a step back on escalating the dose in those other areas that could affect function and quality of life.
Absolutely. Yep. So when a patient comes in and sees you, whether it's a low-grade lesion, a high-grade lesion, how do you kind of balance the hope and realism kind of definitive management, what the future may hold, whether they go through that curative intent treatment, really just that hope and realism as to what to expect after treatment ends?
Yeah, that's a very important thing to think about. And, I often will start the visit asking them what they know about their diagnosis, because patients come in with a variety of backgrounds and frank understanding about what they're going through. Some are very educated and informed. There's a lot of resources online, with some are very good, and patients may come in very informed, and other patients may not even quite remember what the urologist told them. And that's, this information, when you get a big diagnosis like prostate cancer, can be like drinking water out of a fire hydrant. We sometimes say you can't handle it, right? And we need to just take a step back and let people digest what's going on. And so they have had various abilities to do that coming in, but understanding what they know and don't know, and then trying to, of course, bring hope. Whenever you're going through something tough, you want to know that there's hope. You do have to be realistic, and I think we always want to say that we can cure people 100% of the time. That's not the reality, and certain things about a man's diagnosis may mean that they need more intense treatment that they maybe were hoping to avoid, but really trying to help them understand the risk of their cancer and why we need to be less or more aggressive, and why you may not be a candidate for something that someone else is, or why you need something that they didn't, and really help them understand that we never want to cause side effects. Our goal is to do no harm, but sometimes when the cancer is more aggressive, we need to be a little more aggressive and accept some risk of hopefully temporary side effects to get them to the point where they can have their cancer controlled so that it will not get worse and cause worse suffering down the line.
Absolutely. No, that's great. And I think overall, as far as cancer management goes, right, it's been not only an evolution as far as radiation advancements, but also kind of some of the other things we do to make sure our care is the best possible. Things like genomic classifiers, molecular imaging, like prostate-specific PET scans, new therapies that are kind of changing the treatment landscape. How do you kind of incorporate those new latest and greatest advancements into your care and consultations every day?
Yeah, this is one of the most fascinating and game-changing developments that's occurred in the last 5 to 7 years. And, I think it's also important to understand that all cancer treatment should be done in a multidisciplinary fashion. I don't have, and you don't have, a monopoly on knowledge, and what I can offer or you can offer, another physician can offer, is not necessarily the only option, or some are better done together. And certainly hearing multiple opinions or styles of presenting things is important. So I love that we have so many tools, and even working with physicians in the area, I've been able to learn about some of these new things that have come on and implement them in my practice. And yes, PSMA PET scan has really taken off. It was initially available on trial in select locations, and we saw the value of that. But now with the FDA approval and the use of this more routinely, we're getting better understanding about what stage patients are at. We never want to do a treatment that isn't going to help someone. So knowing if the cancer is more advanced and something that we otherwise would have offered isn't going to get them where they want to be or where we want them to be, that's valuable information. And whether that's considering a patient considering surgery and they decide not to because there are lymph nodes involved that surgery is potentially unlikely to cure them, or if a patient is considering radiation or surgery and they have cancer in their bones, or just having more confidence that, hey, we have a really good look outside of your prostate and we don't see anything. It doesn't mean there's no chance, but we're more confident now than we were historically with some of the conventional imaging that we had until recently. So, not only does it help risk stratify people and identify options that they may have that are better for them, it also allows us to be, in a radiation sense, more targeted. We often would treat, again, the prostate uniformly. Now with MRI and with PSMA PET scan, we can identify higher risk areas that we may want to intensify treatment, as I spoke earlier. And then a normal looking lymph node on CT scan may be quite bright on a PSMA PET scan. So instead of just treating the lymph nodes generally that could harbor microscopic prostate cancer and being limited in how much we can give, we actually can know where a primary or potentially a sole source of cancer and PSA production is coming from. So we can really hone in radiation and give a higher dose while minimizing or keeping dose in a safe range to the other areas. So it makes radiation more accurate. It helps patients understand their diagnosis and stage and help providers guide them more appropriately. And genomic classifiers are another huge thing. We only have so much information with a PSA level and a Gleason score from a biopsy and maybe a rectal exam. That's historically what factored into risk stratifying men with localized prostate cancer. And now we have a look under the hood at the genetic signature that may predict a more aggressive or less aggressive cancer and adjust our treatments accordingly. There is some amount of use of genomic classifiers regardless of the stage of the patient. So it's not just a man who's got a fairly unaggressive prostate cancer that's trying to decide if they should do active surveillance or active treatment, or somebody who's considering whether they need salvage radiation after a prostatectomy where there's some adverse features, or a man who's getting radiation and wants to know how much, do I need the ADT with the radiation? And if so, like how much? These are just another look at the individual cancer profile that helps the providers and the patients make better informed decisions, and very powerful.
Yeah, I think from a genomic classifier perspective, I think just having more personalized information on that patient's tumor, right? The NCCN guidelines, we've spoken with others, are kind of broad categories to attempt to risk stratify and kind of give us an idea of the level of aggressiveness or the level of treatment intensity that someone needs. But to be able to send that person's tumor for a specific analysis and get feedback on the biologic aggressiveness to then tailor treatment recommendations is pretty remarkable. And to your point, for patients needing radiation therapy, one of the big sticking points is that hormone therapy, that testosterone reduction, whether it's necessary, how much of a benefit is it going to give me, how long does it need to be, do we need to intensify it beyond what we thought was normal, right? And so adding that information in can help you either be more aggressive or less aggressive to balance that kind of appropriate treatment level where you're not under or over treating someone. So yeah, well, it's exciting to see kind of what the future holds as that continues to evolve, incorporated in with the other information, not only with the pathology under the microscope, but the scans and everything beyond that. So kind of like we just talked about as far as genomic classifiers, PET scans, et cetera, what does personalized medicine really mean for a patient with prostate cancer sitting in your clinic today from a radiation therapy perspective? So how do you personalize the journey for each person?
Right. And it goes back to a little bit about trying to understand where they're at and where they want to be. And any treatment is going to have a potential profile or side effect profile that may be unique, and the things that someone's willing to go through versus not willing to go through to get to a place of prostate cancer control or cure. So trying to understand where they're at now, function, where they would want to be, what they prioritize, and how some people will climb Mount Everest to get to the point where they can say that they're without cancer. And some people, they're looking at a shorter lifespan. They have other medical issues they're dealing with, and they're going to take a more minimalist approach, and that's where everyone's different. But trying to assess where people are, where they want to be, and then synthesize all these different parameters of their cancer to try to understand what is going to be most effective for them and try to meet where they want to be. So that's a big part of my job as a physician is to heal, but not to harm. And part of that harm is, what are they willing to take as far as side effects? And there are so many different ways of doing radiation. I think that's something that's gotten even more challenging is, seeing a patient for a consultation and talking to them about, external beam radiation, brachytherapy, high dose rate temporary brachytherapy, LDR, low dose rate, permanent seed implant, external beam. We've got longer courses of treatment. We've got shorter courses of treatment. We've got really short courses of treatment. We've got active surveillance, which is no radiation. And then are we treating the lymph nodes too? Are we treating the prostate uniformly? Are we going to boost things? Are we going to do a gel? Are we going to do markers in the prostate to help with alignment or facilitate certain treatments? How do we integrate the hormone therapy? And it can be quite a daunting challenge to get through that and have patients not be overwhelmed, but still feel like they came out of there understanding, what their options are.
Right, and I think it just shows how much thought goes into each and every patient, right? It's not just direct that radiation at the prostate, everyone gets the same number of treatments. It's literally all of those multitude of factors that factor into each person individually, which is awesome. That's why outcomes are better. That's why side effects are less. That's why people are living longer,
For sure.
et cetera. So awesome. Kind of similarly, not only has the medicine gotten better and more personalized, but beyond the actual medical treatment itself, what advice do you give patients about lifestyle, diet, mental health during and after their treatment, specifically radiation therapy for prostate cancer?
For sure. I think a lot of people are appropriately looking to be better, healthy individuals and either live better regardless of their treatment or to get through treatment better during and after. And we're always looking for what we're missing, right? And I think there's a lot of information on the internet, and I think that patients have done a good job of trying to seek that out. It can be a little hard to tease out, how helpful certain treatments are, but I think there are certain things that I always advocate, and that's trying to recognize the importance of mental health, especially when you're dealing with a new cancer diagnosis. It can be quite traumatic, either due to concerns about your own mortality or how life may play out and the things that you value may change. Sometimes the fear is beyond what should be. It's irrational, and sometimes it's very rational, and helping people through those things, and mental health is very important. Exercise, diet. I go back to the food pyramid that they taught us in grade school, and really in the American society, it's hard to stick with those things that the fruits and the vegetables and the healthy food, and avoid foods that may not be as good for us in general. And also, there's a lot with diet and cancer. And exercise is certainly very important as well. It helps with mood. It helps with maintaining a healthy body weight. It helps with healing, and it helps people as they recover from cancer and cancer treatment. This is proven in multiple cancers. Sometimes could even lead to people living longer, more free of their cancer. The immune system and the way that works with interactions with cancer, we're only scratching the surface. And I think good mental health, exercise, diet, being able to lean on your friends and family if you have those, they're a valuable resource. And I think that people should leverage that fully to try to deal with their cancer diagnosis and the treatment.
Yeah, and I think you mentioned friends and family, and obviously caregiver burden, meaning the wife or the girlfriend or the significant other or the sister, brother, et cetera, of someone undergoing cancer care can be stressful as well. So I think ensuring that everybody is well taken care of, taking advantage of social work and other resources that are available at each clinic or center is super important, kind of to treat that person and their family or friends holistically to get through that journey there.
Absolutely.
So, yeah.
We haven't always done a great job of recognizing those factors that go into patients as they journey through cancer, and complementary services, and again, the social work, and they do an absolutely crucial job in helping patients navigate this journey.
Absolutely. Yeah, so obviously a lot has been done over the last 5 to 10 years, but now as you look more forward into the 5 or 10 years that lie ahead, What are some of the things from a breakthrough perspective or just a pure excitement for you as a physician within the radiation oncology realm for prostate cancer? What are those breakthroughs or things that are exciting to you as we continue to move the needle in improving prostate cancer care?
Yeah, that's a really kind of a cool area to think about, because I think at the end of the day, a lot of what we focus on is how do we cure this person, right? Like, we're giving radiation, we want to do a good job, we want to cure them, and we want to limit our side effects that we cause. But the unfortunate matter is some men do recur. The cancer may come back, or it may spread somewhere, or some men are diagnosed at a stage 4 or metastatic situation where the cancer isn't curable. And we've had treatments, and they're always expanding. The backbone of palliative treatment meant not to cure someone, but to alleviate suffering, extend life, control the cancer, has been testosterone suppression with ADT. And that can be quite effective for a variable amount of time. We know now that adding additional next generation anti-androgen medications can improve outcomes further. And we know that despite those, eventually many men will progress and need the next line of treatment. In radiation, again, historically, palliative radiation meant patient has pain, has symptoms. We need to knock the tumor back and alleviate those symptoms. Nowadays, palliative radiation may mean this patient has stage 4 cancer that is not going to be cured, but along with these other systemic therapies that are going to help slow the progression of their systemic cancer, we're going to use focal treatment to hit hardest the areas that are more likely to grow, to lead to resistance to cancer, systemic cancer treatments. And in some cases, men may desire to delay moving on to the next line of therapy to either maintain better quality of life or keep that in reserve, or even to avoid needing to start or go back on androgen deprivation therapy. So there is a role for radiation in oligometastatic prostate cancer, which means only a few spots. That definition is constantly being evaluated, and there's a lot of different scenarios that we could think and talk about that. But we are trying to separate curative and non-curative settings when there's really a spectrum. And the optimal way of taking care of patients is often multidisciplinary. It's not just give radiation, just give chemo, give ADT, or whatever targeted therapy it is. Using them together could make it more effective. And there are multiple trials that have been published showing different endpoints that quality of life or progression-free survival, in some cases possibly overall survival is improved by using radiation. And having PET scans, PSMA PET scans, raises the confidence that what you see could be most of what's out there. And I think we've seen this in our own practices, that there are patients that are able to avoid or delay more toxic therapies by using radiation selectively. And because these are often very focused treatments, there are less side effects, and because they're often very short treatments, 1, 3, or 5 treatments, it doesn't interfere with their lives too much. So it's kind of an awesome thing to be able to help someone and not cause a lot of side effects or disrupt their life. So
absolutely. No, that's exciting. And I think not only external beam radiation, but obviously the targeted radiopharmaceutical medicines, things that each and every day there's new advancements, ways to combine. What I'm excited about also is the potential to combine what we do every day here at BAMF, which is these targeted radiation medicines for both prostate cancer and neuroendocrine tumors, but to combine that with things like external beam radiation therapy. And maybe you will get more durable long-term outcomes if it's to manage that cancer over a period of months or years. Maybe in the curative setting, you can need to use less external beam radiation because you can use that targeted radiation from an internal perspective to kind of knock out that dominant nodule and beyond. So I think there's going to be a lot of change as we continue to see the years go by. So
yeah, and you're obviously an expert in that realm, and this is the crux of the issue is in stage 4 cancer. It's not just what you see, right? And radioligand therapy is obviously a very effective treatment to treat metastatic cancer where you see it, but like you said, potentially combining it with systemic therapies or radiation focally is going to help cancer control, and again, use the lowest effective dose of each to limit side effects. And we're really trying to, in a sense, kick the can and help people live longer, but also live better. And this is really exciting.
Yeah, and I think a lot of times the discussions I have with patients includes kind of the ability to manage prostate cancer, kind of like a chronic disease, like we do other things, right? High blood pressure, diabetes, those things are managed over years most commonly. And the more we can get toward management of incurable cancer over years while minimizing side effects, you're kind of optimizing both quality and quantity of life simultaneously, which is super important.
For sure.
So, yeah. So kind of as we conclude today, if you could deliver one key message to patients and families that are listening right now, what would that be?
And that would be definitely, there is hope. And I think it starts with becoming aware of what you're dealing with and what options you have, not being afraid to talk to friends, family, if that's appropriate, or to find a medical professional that you trust, and also to get informed on resources that you can do on your own time. And knowledge is power, and understanding what you're dealing with will help limit anxiety. And depending on what your battle is, a better understanding of what options you have and what you may be going through is going to leave you in a better position to know how to proceed. And a lot of this is based on what you value, right? And what's right for one patient may not be right for another. And I think it's important to acknowledge that as patients talk. We all have different priorities, and never to feel bad if you chose something or there was something unique about your case. But be informed and ask questions and be hopeful.
That's awesome. Well, we appreciate your time today and continue to do great work out there in the community.
Thank you for having me, and as always, I appreciate your role in this community of treating prostate cancer and really pushing the envelope and trying to raise quality and bring new technology and treatment.